to decrease the noise, the background noise. Okay. So we are on to omidriatic cycloplegics. These are drugs that the eye doctor uses, and you probably have gone for an eye exam, and they put drops in your eyes to get a better look in the back of your eyes, dilate your pupil, and then they tell you you can't leave right away, you can't drive because your vision will be blurry. So usually they use the most common drugs are like atropine and scopolamine. That's what you should be. Any of the muscarinic antagonists that are used for eye exams, the nursing teaching would be to avoid, you're photosensitive, your vision may be blurry, to avoid driving. Centrally acting anticholinergic drugs are the drugs that are used to treat Parkinson's disease, as well as to treat the drug-induced Parkinsonism, like, for example, benztropine, which is known as Cogentin. That's a drug that's used to counteract the effects of the first-generation antipsychotic drugs, which primarily have Parkinson-like side effects. So they have motor dysfunction, motor alterations. They have extrapyramidal side effects, which are you taking psych right now?
Yes, we are.
Okay, so you're going to learn all about if you haven't started already, about the patients when they take these antipsychotics. They get drug-induced Parkinsonism, they get extrapyramidal side effects, they get tardive dyskinesia, and when they take these first-generation antipsychotics, we have to give them an essentially acting anticholinergic drug to help decrease the extrapyramidal side effects and control them. So benztropine is one of those that we use. It's called Cogentin. You probably heard of it. And then we have a number of different other drugs that we use for treating Parkinson's disease. And we'll talk about those. Those are these acetylcholinesterase inhibitors. Now, so muscarinic agonists. So we can get overdose of muscarinic agonists, and these are drugs that have cholinergic effects because they agonize the cholinergic receptors. And so we can get it from direct-acting muscarinic agonists, or we can get it from the indirect-acting muscarinic agonists, such as the cholinesterase inhibitors that increase acetylcholine. So symptoms will result from excessive activation of muscarinic receptors, so sludge and killer bees, and the treatment is atropine, which is an anticholinergic agent, antimuscarinic. In terms of muscarinic antagonists, we can get poisoning from natural products, such as atroca belladonna, and we can also get poisoning from overdose of anti-muscarinic drugs, such as atropine and scopolamine, as well as with drugs with pronounced anti-muscarinic properties. And we have talked about those before. Those are some of the antipsychotics, the phenothiazines, the tricyclic antidepressants, so we call them TCAs, and the antihistamines. They all have very strong anti-muscarinic properties. So symptoms of muscarinic antagonists will be the opposite of sludge, right? So it's the opposite of cholinergic. So it'll be dry mouth, blurred vision, photophobia, hyperthermia, central nervous system effects, and these patients, they hallucinate, they get delirious, and they get hot, dry, and flushed skin due to vasodilation, and they can get respiratory depression as well. So the treatment The boards will test you on atropine and physostigmine. The treatment is a cholinergic agent, physostigmine. Now, which will inhibit acetylcholinesterase and decrease the breakdown of acetylcholine at the neuromuscular junction. This physostigmine, this drug comes up on the board, so make sure you know it is the most effective antidote for the treatment of muscarinic treatment of overdose of muscarinic antagonists or anti-muscarinics. So it's important that we're able to differentiate between poisoning and an actual psychotic episode when a patient has overdosed with an antipsychotic. The reason for that is that they have the same symptoms. They resemble each other. So when a person is psychotic, they hallucinate, they're delirious, and when they have anti-muscarinic poisoning, they also will hallucinate and have central nervous system alterations. They get completely delirious. The difference is that if a patient, the way you can tell is that if a patient is truly psychotic, right, and so it could be from underdosing of the medication or poor adherence to the medication. If they're actually psychotic, you don't see the signs of you don't see anticholinergic signs, right? So you don't see the anti-sludge signs, all right? So you don't see the dry mouth, you don't see the hypothermia, the dry skin, all right? But so it's sometimes it's not that hard to figure out, all right? So number one, the nurse teaches a patient about ethanol, and you see the name colon in the brand name, colon in the generic name. So it tells you it's a cholinergic agent. Which statement by the patient requires an intervention by the nurse? A, the medication should be taken with meals. And this is this here is a little, again, a little difficult to tweeze out, but you will, if you know what the symptoms of using cholinergic drugs are. Okay, so you always go back to sludge and killer bees. So the medication should be taken with meals. Urgency may occur, so I should be near a bathroom. I should plan to take the drug 3 times a day, and this drug may cause a drop in my blood pressure. It's the right answer. Charmaine, it's on the slides. The physostigmine is on the slides. So which statement by the patient requires an intervention by the nurse? Can the drug cause a drop in blood pressure? So Annie says D. Can the drug cause a drop in blood pressure? So it's a cholinergic drug. Okay. Cholinergic drug causes killer bees, causes bradycardia, it causes vascular changes, vascular dilatation. I should plan to take the drug 3 times a day. That you wouldn't know unless I tell you, but you can kind of like tweeze out the right answer, because the thing with cholinergic drugs is that it can make you nauseous and vomit, right? Because with cholinergic drugs, everything is increase in secretions, right? So you get diarrhea, you get abdominal cramping, you get nausea, vomiting. And so the right answer is A. The medication So the patient requires an intervention by a nurse if she says that I should take this medication with meals. If you take it with meals, it'll make you vomit. Or it'll increase, no, it won't make you vomit. It'll increase the risk of vomiting and nausea because of the cholinergic effects. So Cole is right. The answer is A, yes. A patient is prescribed methanocol for urinary retention and okay. Well, I'll say what I want to say in terms of methanocol in this question and the urine and the bladder. So they're using this drug for urinary retention. If the patient exhibits signs of an overdose, such as increased salivation and sweating, bradycardia, or hypertension, which medication should the nurse administer? So the patient is taking a cholinergic agent, methanocol, and they have increase in sludge, right? Which medication should the nurse administer to block sludge? Which one is an antimuscarinic? Okay, Tyler, Cole, Jen, D is the correct answer. Yes, atropine. Oxybutynin, acetylcholine, cevimeline, these are all drugs that are sludge inducing. A patient who takes oxybutynin, ditropan for an overactive bladder, takes an over-the-counter antihistamine. So they're taking oxybutynin for an overactive bladder, takes over-the-counter antihistamine for hay fever. What symptoms should a nurse watch for that would indicate toxicity? So oxybutynin. Is oxybutynin a cholinergic agent or an anticholinergic agent? So you have so antihistamines have prominent antimuscarinic agents, phenothiazines, and TCAs have anticholinergic agents or have antimuscarinic properties. And so you're mixing it with oxybutynin, which is an anticholinergic drug, and so you're going to have signs and symptoms that are anti sludge. B, dry mouth, increased temperature, and blurred vision due to pupillary dilatation. And we know that anticholinergic agents cause dry mouth. So Miguel, you are right. Question 4. A patient is brought to the emergency department with hallucinations related to TCA overdose. TCA, we know with the phenothiazines and the antimuscarinics and the antihistamines, they have significant antimuscarinic properties, anti-sludge properties, anti-killer bee properties. So the patient has hot, flushed skin and oral temperature of 103. Which medication should the nurse prepare to administer as an antidote to a patient taking a TCA? Tyler, yes, I'll get back to that. So which drug is, you're taking a drug that's antimuscarinic? TCA is a tricyclic antidepressant. So TCA is a tricyclic antidepressant. Phenothiazines and the antihistamines, they all have strong antimuscarinic properties. You're giving a patient a TCA, and the skin is hot, they're flushed, they have a high temperature. What is the antidote for antimuscarinic agents? We just talked about this. Yes, Tyler C. Physostigmine is a cholinergic agent. We have to give them a cholinergic agent. Correct. Physostigmine. Mestinon. Yes.
I think you're right. Are you done with this question?
Say that again.
Are you done with this question? Because I'm going to interrupt you with this question.
Oh, give me 1 second. I was going to make a point about pyridostigmine. And Mestinon is an oral drug that's used to treat people with neuromuscular, like the autoimmune neuromuscular diseases. Hang on 1 second. Let me just shut this door because there's noise. Sorry. So go ahead. Sorry. Go ahead.
So for question 1, I know that you said that the answer was A, right?
Question 1, A. Mm-hmm. A? Hold on. Let me see.
Was it A?
Was it? No, I don't know. Was it medication should be taken with meals? Yes.
I thought it should be taken stomach.
So the patient is saying that they should take it with meals. So the nurse would be required to teach them not to take it on an empty stomach.
Oh, okay. Sorry, I misread that. Thank you.
Yeah, I do that all the time too. Yeah, sometimes I have to reread the questions myself. So yeah, but yeah, because of the nausea and vomiting, you should take it on an empty stomach, and so A is the right answer. Okay, so we're done with 14. Hang on 1 second. Next chapter is chapter 15. Okay, so cholinesterase inhibitors and their use in myasthenia gravis. So cholinesterase inhibitors, they're drugs that prevent the degradation of acetylcholine by acetylcholinesterase. And as we know, myasthenia gravis is a condition where it's an autoimmune disease where we make antibodies against the receptors on the motor end plate that prevent binding of acetylcholine to the receptors, hence decreasing muscle strength. And so by decreasing the breakdown of acetylcholine when we give these drugs, we indirectly will antagonize the receptor by having more acetylcholine available. So they lack selectivity, meaning that they will interact with, it will cause other muscarinic receptors to get activated, and they have limited therapeutic applications. So, so one of the first drugs that we use, neostigmine. Neostigmine is a drug that is used to treat myasthenia gravis. It's one of the reversible cholinesterase inhibitors, and it prevents the hydrolysis of acetylcholine. We talk about irreversible cholinesterase inhibitors, and they're not truly irreversible only because they bind to the receptors, and once the receptors, they stay there. But once they're bounded and the receptors turn over and we have no receptors, then the effects will wear off. So they're longer acting because of their reversible binding to the receptors, but they're not there forever. Now, neostigmine cannot readily cross over membranes because it is a charged compound, and it will not cross over membranes, and hence, even though we can give it orally, crossing over the gastric membrane, the mucosal layer, is difficult because it is a charged compound. It has minimal effects on the brain and the fetus because again, it doesn't charge. It doesn't. It's charged. It doesn't cross the placenta. It doesn't cross well over the blood-brain barrier, and it's a poor substrate for cholinesterase. So again, this drug is used to manage myasthenia gravis, and it prevents the breakdown of acetylcholine, hence making more acetylcholine available at the motor end plate, the neuromuscular junction, which once you have acetylcholine, it can cause muscle movement, which is what you want in somebody who has myasthenia gravis. So it intensifies transmission of virtually all junctions where acetylcholine is neurotransmitter. It's not a drug that is specific for one muscarinic receptor or one cholinergic receptor, I should say. So the muscarinic response, all right, is identical to if we gave a direct acting muscarinic agonist. All right, so muscarinic response identical to those of the direct acting muscarinic agonist. They prevent the breakdown of acetylcholine. They can cause bradycardia. So again, it's cholinergic in nature. So killer bees and sludge. All right, so at therapeutic doses of neostigmine, it increases the force of contraction in the skeletal muscle. At toxic levels, it decreases the force of contraction. And so if a patient has an overdose of neostigmine or any cholinesterase inhibitor, what it will do is resemble the patient having an exacerbation of myasthenia gravis because the patients get weak, they get poor muscle function with overdose. So that's the neuromuscular effects. Central nervous system effects at therapeutic levels, patients can get mild stimulation, and at toxic levels, they can get depression of the central nervous system. All right, so this drug is used to treat myasthenia gravis. It's also used to treat. It's used in the operating room to reverse neuromuscular blockade when the non-depolarizing neuromuscular drugs like pancuronium or vecuronium are used to paralyze a patient. It's not used for the depolarizing neuromuscular blocker called succinylcholine. Because if you use it with that, succinylcholine is a depolarizing neuromuscular blocker. If you give it, because this drug causes depolarization, right? So if you give it in conjunction with a depolarizing neuromuscular blocker, what you will in fact do is prolong the paralysis and prolong the effects by prolonging the effects of the depolarizing neuromuscular blocker called succinylcholine. So it's only used for the non-depolarizing neuromuscular blockers. So it's used post-operatively to reverse the paralysis. All right. It's also used, of course, with in response to for treatment of overdose of a muscarinic antagonist, and it's likely to elicit substantial muscarinic responses, meaning that it can increase sludge and increase killer bee. And so a patient may have atropine administered to dry up the secretions, to increase the heart rate, and most importantly, to keep the heart rate up. Adverse effects. Well, it's a cholinergic agent, so patients will have signs and symptoms of excessive muscarinic stimulation, so sludge and killer bees. All right, again, when we talk about neuromuscular effects, if you have too much of neostigmine, it can cause muscle weakness, right? So too much of it can lead to paralysis of the respiratory muscles if they are excessively dosed. So muscle weakness, muscle paralysis. And of course, that's a big concern because patients can stop breathing. When these patients are getting these drugs in the operating room, they have an endotracheal tube in. Okay, so to reverse it, we can use a muscarinic antagonist such as atropine. Atropine is given only by IV in IV form. It doesn't come as an oral medication. It's only given intravenously. Precautions and contraindications: obstruction of the GI tract or urinary tract, peptic ulcer disease. Of course, everything that's sludge and killer B related, it will exacerbate. So peptic ulcer disease, it can increase the amount of. Hang on 1 second, please. Sorry about that. So with giving these muscarinic agents, it can exacerbate peptic ulcer disease because, of course, it increases gastric secretions. With asthma, it causes bronchorrhea, bronchospasm, coronary insufficiency, lowered blood pressure, lowered heart rate, and it can impair myocardial perfusion and hyperthyroidism. It exacerbates, it causes the effects of hyperthyroidism to be exaggerated, and so it can lead to the myocardium being exquisitely sensitive to catecholamines, making the patients get things like dysrhythmias. They can have chest pain or angular symptoms because of coronary insufficiency. So it has significant cardiac effects. All right. So drug interactions. Okay. Why does it say paused here? No, I'm recording, right? It's recording in progress. Okay. Okay, so in terms of drug interactions, obviously it's going to have competing effects with the muscarinic antagonist. Non-depolarizing neuromuscular blockers, they will counteract, and depolarizing neuromuscular blockers. Okay, thank you. I'll fix that. Oh, please. It's still, yeah. Can you see? Fixed. Okay, great. Thank you. Okay. So in terms of non-depolarizing neuromuscular blockers, it will have an antagonistic effect. So reverse non-depolarizing neuromuscular blockers and exacerbate or prolong the effects of depolarizing neuromuscular blockers. All right, so here's just a list of some of the reversible cholinesterase inhibitors. One that stands out that we're going to talk about a little bit is edrophonium. Edrophonium is known by the trade name as Tensilon. And Tensilon, we can do a Tensilon test. That's how we can tell if a patient with myasthenia gravis is having a too much or too little medication. This drug, and people with neuromuscular diseases that affect acetylcholine. So this drug, the Tensilon test, it will by giving edrophonium to somebody who has myasthenia gravis, you would giving it to them will increase the muscle strength if they are in a myasthenic crisis. But if they are overdosed, because they look the same, if they're overdosed on their cholinesterase inhibitor, it will make the symptoms worse. And there's a whole section on that we're going to talk about in a little bit. The thing about edrophonium that you should know is that it has a very short half-life. It's like 9 seconds. Yeah, but about 9 seconds. And so you have to push it very fast, and the effects of it wears off significantly in a short period of time. So if you were to give it to somebody and exacerbate their overdose of acetylcholine, the effects don't last long because it wears off quickly. It has a very short half-life. Anytime you're doing anything like a 10-to-1 test, you really need to have like emergency equipment nearby too, in case if you're trying to diagnose if a patient has a myasthenic crisis or they're overdosed on acetylcholine, you have to have emergency equipment necessary, because if they in fact have overdosed and you're giving them more of what they've overdosed on, then it could potentially lead to respiratory arrest. All right. And then drugs for Alzheimer's, we'll talk about that in a little while. It's a little chapter on that. So the irreversible cholinesterase inhibitors, they're highly toxic, primarily used as insecticides. They're called organophosphates. So your boards may present it to you. Your patient came in contact with an organophosphate, which, by the way, they're highly lipid soluble, and they can enter just by contact with the skin, inhaled. It's very, very lipid soluble. So we don't really use these drugs clinically. We only use it for glaucoma. So they readily absorb from several routes, and there's potential for use in chemical warfare. All right, so sources of poisoning, again, organophosphates, like insecticides, and the symptoms will be that of a cholinergic crisis, so sludge and killer bees. The treatment, mechanical ventilation. They stop breathing because of the weakness. We also can give them diazepam because they seize. They get seizures, so we treat the seizures with diazepam, which is a benzodiazepine. And we can give them pralidoxime, which is a drug that has to be given immediately after the patient has been poisoned, because the longer the wait or the interval between contact with the poison, the less effective the drug. And it also depends on which insecticide the patient gets. Some insecticides have a very long half-life, so if you gave it a little later, it wouldn't matter. Some insecticides have a half-life of about 9 seconds or 10 seconds, like in seconds. So it depends on which insecticide also that the patient has been exposed to. But your boards will test you on this drug. All right, we have to give anticholinergics. We have to give pralidoxime, which is the specific antidote for treating poisoning. All right. We give atropine to control the sludge and killer bees. All right. And pralidoxime, it just inhibits cholinesterase. So yeah. So these are we can give lorazepam, we can give diazepam for treatment of seizures. That you see when patients get a cholinergic crisis. So just remember pralidoxime, diazepam, lorazepam, and atropine. Myasthenia gravis, I mentioned to you before, it's a neuromuscular condition that is a chronic condition that that's caused by an autoimmune, it's a type 2 hypersensitivity reaction. Remember that? It's an autoimmune disease, and these it's characterized by periods of remission and exacerbation. So common symptoms you need to know for the boards. Common symptoms, they have like droopy eyelids, that's called ptosis, dysphagia due to muscle weakness of the esophageal muscles, and weakness of the skeletal muscles. One of the things your boards will ask you about myasthenia gravis is making sure that the patient can drink the water when you're giving them their medication, or they can swallow properly, because if they can't, and you constantly have to evaluate their muscle strength, especially when it comes to swallowing, because they can aspirate and end up with aspiration pneumonia, which is not good either, because people do die from aspiration pneumonia. So, so these are the common symptoms, and the boards like to ask you about ptosis and dysphagia and skeletal muscle weakness. All right, so treatment with cholinesterase inhibitors. Why? Because it increases acetylcholine at the neuromuscular junction, thereby increasing muscle strength. Side effects, it is a cholinergic agent, and so it will cause killer bees and sludge. So dose adjustment, like any other medication, we approximate the dosing. So we start small and we adjust to the patient's response. May need to modify dosage in anticipation of exertion, and that's something the boards will ask you as well. So if you, they'll say something like your patient has myasthenia gravis, and usually walks one block or 2 blocks a day for exercise with no symptoms of weakness. Today, your patient decides that she is going to the mall to hang out with her friend. Which of the following would you advise the patient to do? And the right answer would be the person would need to adjust their medication in anticipation of exertion, because they're not used to, if they're not used to going to the mall and walking around the mall for hours, they're going to get weak in the mall. And so they would have to adjust their medication. And that's not, you don't tell them the dosage. The physician will tell them, how much to take if they anticipate extra exertion on a particular day. So the patients know that if they're going to overexert more than normal, they have to take extra medicine. Okay? So signs of undermedication, this is something the boards will ask you as well, is ptosis and difficulty swallowing or dysphagia. And signs of overmedication will be muscarinic in nature. You see them drooling, okay? See the patients drooling. Okay, so I mentioned before the myasthenic crisis and cholinergic crisis. So myasthenic crisis and cholinergic, it's important that we're able to differentiate which one the patient is having, because a patient with myasthenia gravis can have either or. If they're over-medicated, they can get a cholinergic crisis. If they're under-medicated, they can get a myasthenic crisis. And they pretty much, again, look the same. They get weak. They get respiratory muscle failure. They get skeletal muscle failure. So they pretty much look the same, except the cholinergic crisis. They have symptoms of excessive muscarinic stimulation, i.e., sludge. Right? They're drooling a lot, and they have and they can have the other symptoms related to sludge. With myasthenic crisis, they do drool as well, but the symptoms are more pronounced. The cholinergic symptoms are more pronounced when a patient is having a cholinergic crisis, and so if we want to determine what crisis they're having, all right, we can give them a cholinesterase inhibitor, all right, to check them out. So that would be the tensilon test, or the edrophonium. Edrophonium, short half-life, you inject it into the patient. If they're having a myasthenic crisis, guess what happens? The muscles get stronger, all right, because they're lacking cholinergic stimulation. If they have a cholinergic crisis, the symptoms will get worse. Okay, so for cholinergic crisis, they have extreme muscle weakness or frank paralysis and signs of excessive muscarinic stimulation, treatment with respiratory support, and we want to give them an anticholinergic, which is atropine sulfate. For myasthenic crisis, if we want to determine, we talked about determining if there's a myasthenic crisis, so we want to increase the medication and treat the muscle weakness with a cholinergic agent such as neostigmine to increase the muscle strength. And so when we are medicating our patients, it's a we have to work our way up to get them to the adequate dosage. Again, they have extreme muscle weakness when they're in crisis, and they can go into respiratory failure and require mechanical ventilation because of respiratory muscle weakness. And now this is due to not excessive acetylcholine, it's due to a lack of acetylcholine, right? And if it's not treated, it can result in death due to respiratory muscle paralysis. All right, so distinguishing myasthenic crisis and cholinergic crisis, we talked about the challenging dose of etrifonium. We want to do a history of medication use or signs of excessive muscarinic stimulation to assist with differentiating one or the other. And of course, the patient can help you identify what the issue is. The nurse instructs a patient with myasthenia gravis who's taken neostigmine. Which statement, if made by the patient to the nurse, indicates an understanding of the instruction? So neostigmine, A, the antidote for this medication is norepinephrine. B, an extra dose should be given if paralysis occurs. C, a medical alert bracelet should be worn at all times. D, the medication will be prescribed for 2 to 3 months. So just go through these, and maybe if you don't know the answer, you can kind of do a process of elimination. And so you can start by looking at D. Is this a medication that's prescribed for 2 to 3 months? No, it's not, because it's a chronic condition. And there's no cure, but we control the symptoms, so it's not going to be prescribed just for 2 to 3 months. C, a medical alert bracelet should be worn at all times. Could be. B, an extra dose should be taken if paralysis occurs. Is that true? Do we want to give an extra dose of neostigmine if paralysis occurs? Yes, no, maybe so? No, right? Because if they're having a cholinergic crisis, it'll make it worse. It's okay to give etrifonium because it's in and out, but not neostigmine. The antidote for this medication is norepinephrine. Is that true? No, it's not. So the correct answer by process of elimination is a medical alert bracelet should be worn at all times. The nurse cares for a patient with myasthenia gravis. Before administering pyridostigmine, mestinon, it is most important for the nurse to take which action? A, assess the patient's ability to swallow a sip of water. B, cleanse the patient's skin before applying the transdermal patch. Ask whether the patient has an allergy to aspirin, or give the patient food or milk to prevent stomach upset. Yes, Cole and Jen, you guys are correct. It's A, assess the patient's ability to swallow a sip of water. If they can't swallow a sip of water because they have, the speech therapist has seen them and determined that they can't swallow thin liquids, because thin liquids are the concern. Like, it easily gets into the lungs versus something that is thickened. So the speech therapist will tell you that they did a swallowing evaluation and the patient can have applesauce or honey consistency. Then you would have to give them with whatever consistency liquid the speech therapist has prescribed or recommended. The patient who has myasthenia gravis reports extreme muscle weakness. Which of the following medication should the nurse prepare to administer to distinguish myasthenic crisis from cholinergic crisis? A, B, C, or D? A, B, C, or D? Which is the drug that we use? Yes, edrophonium, tensilon. Ecothiopate is a drug that's used just for the eyes. That's not used for myasthenia gravis. So glaucoma. Atropine is an anti-muscarinic. It's used to treat. Um, it's used to treat cholinergic crisis, insecticide poisoning, and it's used to treat bradycardia in the cardiac setting. Any questions? Okay, next chapter is. One second, let me put the next set of slides. Oh, 1 second. I'm just trying to get these PowerPoints up.
Yeah.
Okay. Adrenergic agonists. So, adrenergic agonists are drugs that be used to agonize the adrenergic receptors. And these drugs are used in the cardiac setting. They can be used in the dental setting, like we use epinephrine to decrease bleeding at the site of dental surgery, decreasing the absorption of lidocaine. It's used in emergency settings, like in the EpiPen, to prevent allergic reactions, anaphylaxis. So it's used in offices to, again, in regular urgent cares, ERs. They're used in many settings to treat a multitude of conditions. So epinephrine is a drug that has multiple therapeutic uses. We use it to, as I said, decrease the absorption of lidocaine, which is local anesthetic. Lidocaine is an antidysrhythmic drug, and obviously, if we're trying to infiltrate tissue to do suturing, or drain an abscess, and that we're gonna cut into the skin and drain an abscess, we want to keep the lidocaine in the area where we're working, and so we don't want to get into the systemic circulation. So we would give epinephrine with the lidocaine to cause vasoconstriction in the area to prevent systemic absorption of the lidocaine, which, if it gets to the heart, can cause arrhythmias. It also, by vasoconstriction, will control superficial bleeding. It elevates blood pressure in people who need elevation of blood pressure. It's a sympathomimetic. It mimics the sympathetic nervous system. And so patients who, for example, may have cardiovascular collapse or who are hemodynamically unstable, we can start epinephrine on them. This is a patient in the ICU. This is not somebody who is, on a regular floor. It's a sick patient. This chapter is 17, I believe. Is it 17? 17, yes. Okay. So it overcomes AV block. If a patient has an atrioventricular block, or it will improve transmission of impulses through the AV node and increase the heart rate. It's sympathetic in nature. Restores cardiac function during arrest. It's a drug that's used as part of ACLS protocol in somebody who has cardiac arrest. It's a drug that causes bronchial dilatation in patients with asthma. And, you have to be almost near death's door if you're coming to an asthma attack to get something like epinephrine. And it's a treatment of choice for anaphylactic shock. So epinephrine can be given IVs. You give an IV, can be given IM, can be given subcutaneously. It has a short half-life, and so if we're giving it to control blood pressure, we'd have to give it intravenously and continuous. Adverse effects, it's sympathomimetic, so it's going to cause it causes the patient's blood pressure to go up, so it causes a hypertensive crisis. Epinephrine is sympathomimetic, so it can cause the myocardium to become sensitive and to firing, and so it may lead to dysrhythmias. Angina, just think about it. If a patient has underlying cardiovascular disease, let's say they have a coronary artery block, and you give them epinephrine, what you're in fact doing is increasing their cardiac workload, because it will cause the blood pressure to go up, it will cause the heart rate to go up, and it will lead to decrease in oxygenation of the myocardium, leading to angina. Necrosis after extravasation. Extravasation is when you have a angiocath in the patient's arm, and it slips out of the vein. Have an angiocath in the patient's vein, and it slips out of the vein, and it gets into the tissue. So the tip is sitting in the tissue. So it's infiltration. It sits into the tissue, and then you don't notice it at epinephrine or any of the vasoactive drugs, right? Epinephrine, dopamine. Dopamine, the boards love to ask you about dopamine causing extravasation and tissue necrosis and how to reverse it, which we're going to talk about in a little bit. But any of these drugs that are vasoactive in nature, meaning that they are sympathetic in nature and they activate the alpha receptors that can cause vasoconstriction. If it extravasates and you don't treat it, it can lead to tissue necrosis. Okay, so it's important. So the boards will ask you things like, how do you monitor your patient? How often do you monitor your patient? And you have to monitor your patient's IV site on a regular basis. If necessary, do not ever give it peripherally. These drugs, like I said, they're usually administered in the ICU setting. I've never seen anybody get epinephrine peripherally, and the reason for that is because of the risk of skin necrosis if it extravasates. So we usually put a central line in that's that goes into a larger vein, and we will infuse it through the larger vein. How do we give dopamine? Like dopamine is one that be given a regular floor through a peripheral line. That can be a problem if you don't have a good IV site and the IV happens to get into the tissue. Hyperglycemia, all right, comes from beta 2 activation. It'll raise the blood sugar. So basically, this is a problem for people who are diabetic if you're giving them epinephrine, because it will raise their blood sugars, and we'll have to adjust their medication, such as insulin, to treat the hyperglycemia. But we know a sympathetic response is to activate those beta 2 receptors in the skeletal muscle so we can fight or flight, right? So sugar goes up, and the question will come probably in the form of your patient is diabetic and they're taking epinephrine. What do you expect to do with the medication in terms of adjustment? Another thing that happens with, I'll talk about that later. So Hypertensive crisis, vasoconstriction is a result of excessive alpha 2 activation. These patients get a dramatic rise in blood pressure. That's not a lie. And they can get cerebral hemorrhage as a result of increased cerebral perfusion pressure. Dysrhythmias, due to the excessive activation of beta 1 receptors in the heart, can cause the dysrhythmias. Cautious use in patients with hyperthyroidism. Again, people with hyperthyroidism are prone to developing dysrhythmias, and the hyperthyroid state makes these people extremely sensitive to catecholamines, and so they can get epinephrine-induced dysrhythmias. Angina pectoris increases the myocardial workload, increases the myocardial oxygen demand by activating beta 1 receptors in the heart. That increases cardiac output because it increases the squeeze, it increases the heart rate, it increases the blood pressure. So the heart is whipping away, the heart is squeezing away, and the heart has to overcome that high pressure in the aorta to get the blood out, and so it can lead to angina, especially, again, in people with underlying cardiovascular disease. Necrosis after extravasation, local injection of phentolamine, which is an alpha adrenergic antagonist to the area to vasodilate the area. All right, so phentolamine. You also hear, oh, really, Tyler? You know, in all the years I've been in nursing, I've never seen it happen, but that's because I've always worked in ICU. Well, no, I haven't always worked in ICU setting. I worked everywhere, but I've only seen it. No, I've seen dopamine on the floor. I gave dopamine on the floor a lot. But epinephrine only in the ICU area. And when these patients are in the ICU, they have central lines, so we don't give epinephrine. And even the patient codes on the floor before they get to and they have to start an epinephrine drip, because remember, it has a very short half-life. So if they're pushing the epinephrine through a peripheral line, while that's happening, they're trying to put a central line in so they can start a drip and get the patient off the unit. Oh, wow. Yeah, it does happen. The tissue gets necrotic. That's interesting. Wow, yeah, I've not seen that, but it happens. All right, I was going to type something and I forget. Oh, phentolamine. You'll hear people say Regitine. Regitine is the brand name for phentolamine. So you'll hear me say Regitine sometimes. Sometimes I say Regitine just out of habit. Everybody's like, oh yeah, Regitine. So that's an alpha adrenergic antagonist. That's a board question, test question, board question. Make sure you know it. Okay. So that's what you inject in the tissue if you notice that there's extravasation to promote blood flow back to the area. All right, again, hyperglycemia from beta 2 activation in the liver as well as in the skeletal muscle. And of course, we'd have to dose adjust the antidiabetics. Oh, monoamine oxidase inhibitors, MAOI, one of the enzymes that inactivate epinephrine and other catecholamines. So if you block the inactivation of epinephrine, all right, if you block the enzyme that breaks down the catecholamines, it can lead to significant hypertension, okay? And it will prolong the effects of epinephrine. So people with MAOI should not be receiving epinephrine. Of course, if they're dying and they were taking MAOIs the day before, then you got to weigh the risks and benefits because it will keep them alive, epinephrine. TCAs, tricyclic antidepressants. Board question, TCAs, they cause dysrhythmias. Usually antidepressants, if you overdose on many of the antidepressants, you don't die, except TCAs. All right, like the standard, the SSRIs, the SNRIs, the risk of death is much less than if you overdose on TCAs. If you overdose on TCAs, it's a wrap. All right, because these drugs, they cause significant dysrhythmias. They cause ventricular dysrhythmias. All right, so TCAs, they block the uptake of catecholamines into adrenergic neurons. Blocking uptake can intensify and prolong epinephrine effects. All right. Patients receiving a TCA may require a reduction in epinephrine dose. All right, so taking a TCA can cause hypertension, significant hypertension or hypertensive crisis. General anesthetics, they inhaled the volatile gases, the ones that, they put the gas over your face in the mask, that's the one we're talking about. General anesthetics, they make the myocardium sensitive, and so it can cause dysrhythmias. So put that together with epinephrine, you get the highly sensitive myocardium that's firing away, and the ventricles will have excessive firing, and they get ventricular tachyarrhythmias, and they can go into ventricular tachycardia, ventricular fibrillation. All right. Epinephrine is an alpha agonist, so an alpha antagonist, they will have competing effects. So, because the alpha adrenergic blocking agents, they sit on the receptors on which epinephrine has to bind. So these drugs, whenever we have a patient, just one second, whenever we have a patient who is taking alpha blocker, it can actually decrease the effectiveness of epinephrine. Or we can give an alpha adrenergic blocking agent to reverse excessive epinephrine. Okay, and brings the pressure down. We use alpha blockers for blood pressure management today, as well as prostate, enlarged prostate symptoms, which we'll talk about in a little bit. So, alpha adrenergic blocking agents can be used to reverse the effects of epinephrine because they compete with epinephrine. Beta adrenergic blocking agents, we talked about those. Those are the LOL drugs. All right. They bind to the beta receptors and can block the effects of epinephrine. So it lowers blood pressure, lowers heart rate, lowers contractility of the heart. General anesthetics, several inhalation anesthetics render the myocardium hypersensitive to activation by beta-1 agonists, and so there's a potential for tachydysrhythmias. Okay, and so drugs that block the alpha adrenergic receptors can prevent alpha adrenergic receptor activation by epinephrine. Alpha blockers, such as phenethylamine, can be used to treat toxicity, such as hypertension or local extravasation, local vasoconstriction caused by excessive epinephrine. And the beta blocking agents will block the beta receptors, the beta adrenergic receptors, right? And it prevents the actions of epinephrine. So these are the LOL drugs. Right, so LOL drugs will decrease anginal pain because they decrease the myocardial workload. They decrease their negative inotropes, so they decrease the contractility of the left ventricle. They will block the beta receptors and decrease heart rate and decrease blood pressure, and hence decrease cardiac workload and decrease the risk of angina. So epinephrine can come as an EpiPen, or it'll be just, it's a solution. Can be given IM, can be given IV, can be given subcutaneously. We can also give it intracardiac in the OPC setting when a patient, for example, has open heart surgery. Patient codes, you can't do chest compressions. They just have staples, on the sternum. Can't go doing chest compression. You have to open up the chest. And so when patients in the cardiothoracic ICU, when they code, we don't do a code the same way you would on the floor. We do open chest codes. So in that setting, if a patient is coding, we inject the epinephrine directly into the myocardium. All right. It can be used intraspinal, can be used as inhalation, and topical. Norepinephrine. All right, norepinephrine is a drug. We call it Levophed. When I used to be in nursing, back my 4-year program, my baccalaureate program, and I learned about norepinephrine. Norepinephrine was not a drug that anyone, that was looked down upon. Like there was a saying, "Levofed, leave them dead." You have to be really, really sick to be on Levofed, just like epinephrine. All right, so Levofed, leave them dead. That's norepinephrine. It has specificity for alpha 1 receptors, alpha 2 receptors. Those are in the vasculature to cause vasoconstriction, and the beta 1 receptor. So it's a catecholamine. Very similar to epinephrine. All right. They work on the same receptors: the alpha 1 receptors, alpha 2 receptors, beta 1 receptors. All right, but it will not work on beta 2 receptors, as you can tell. So if somebody was having an allergic reaction, let's say they're having anaphylaxis, we want to give them norepinephrine because it won't bronchodilate them. We want to give them epinephrine because that's what happened. That's part of the whole symptomatology of anaphylaxis, right? You get bronchial constriction. So because norepinephrine has no effect on beta 2 receptors, it won't cause bronchodilation. But it is a catecholamine, just like epinephrine, and it's used when patients have cardiovascular compromise and they're hemodynamically unstable. So it's used in hypertensive states when it's very difficult. It's a long walk to get somebody to norepinephrine. Again, and this is an ICU drug. And so the patients have to be really sick. So if they're in a shock state, we can give them norepinephrine to bring the blood pressure up, epinephrine as well, and in cardiac arrest. Right, so again, it differs from norepinephrine. It does not activate beta 2 receptors, does not promote hyperglycemia, because remember the beta 2 receptors are in the liver and in the skeletal muscle. So because it doesn't activate beta 2 receptors, blood sugars will not go up. All right. Cannot be given orally. It'll get broken down by monoamine oxidase and the cattle O methyltransferase, which are the enzymes that break down catecholamines. If a patient gets infiltration of norepinephrine, it causes necrosis locally, and it has interactions with MAOIs, TCAs, as does epinephrine, general anesthetics, and adrenergic blockers. Dopamine is a drug that is used. We use dopamine for increasing cardiac output. It's a drug that is a positive inotropic agent, and you see it used in patients who have congestive heart failure. It's also used to bring the blood pressure up, even if a patient does not have congestive heart failure. And sometimes it's used in patients who have low flow to the kidneys, because in low doses, dopamine in low doses will increase renal perfusion. All right, so dopamine, it has receptor specificity for, of course, dopamine receptors, beta 1 receptors, and alpha 1 receptors. Now, these drugs, by the way, when we're dosing patients with these catecholamines and these vasoactive drugs, we dose them based on their weight. All right, so we'll dose them based on milligram per kilogram per minute. Milligram per kilogram per minute. So low therapeutic dose is considered about 1 to 3 mics or micrograms per kilogram per micrograms per kilogram per minute, or milligrams per kilogram per minute. So dopamine is dosed in micrograms per kilogram per minute. So 1 to 3 micrograms per kilogram per minute is considered low dose. So 1 to 3 mics, it'll raise the pressure, it'll increase cardiac output, it'll increase renal flow. And that's all that's needed for renal perfusion. And then the higher dosing, all right, it'll increase the blood pressure even more, because it's activating and increasing the squeeze on the heart even more because it's activating dopamine receptors and beta 1 receptors. And then at very high doses, which is like 20 mics, it will activate the alpha 1 receptors, thereby causing vasoconstriction. They activate the beta receptors, beta 1 receptors, not beta 2, and dopamine receptors. So you get multiple receptors that it will work on at high doses to increase blood pressure and increase cardiac output. So for therapeutic uses, it's used in shock states to increase vasoconstriction, increase cardiac output, increase renal perfusion. All right, so we want perfusion of tissue. It's used in heart failure to increase myocardial contractility in patients who may present with an acute exacerbation of systolic heart failure. Adverse effects of dopamine: it causes tachycardia, it causes dysrhythmia. Sometimes you start dopamine, you look in the monitor, and the patient is starts having PVCs. Just keep an eye on it. More than 6 PVCs a minute is concerning. If you start a patient on catecholamine and they weren't having PVCs before, and all of a sudden they're having PVCs, if they're having more than 6, it needs to be addressed because they're gearing up to have way more. All right, so tachycardia, dysrhythmias, and anginal pain. Why? Because it increases myocardial workload. It increases the oxygen demand of the heart. And this is the one that the boards love to ask about necrosis with extravasation, and the treatment would be phentolamine. Just the drug interactions are the same as the drug interactions that you saw for epinephrine. And it's a good interaction with diuretics. When we give dopamine with diuretics, they work in sync with for the kidneys. Okay, increasing function of the kidneys. Okay, and improving urinary output. Sometimes when patients start to go into renal failure, their urine output drops. Giving them dopamine and furosemide, for example, together increases the urine output. Preparations, dosage, and administration. So dopamine is a high alert drug. And the reason it's high alert, we know that high alert drugs are the drugs that have been identified as the drugs that many medical medication errors are made with. So dopamine and dobutamine, they're high alert drugs. Dopamine and dobutamine, they're packaged the same. I don't know if that's still the case, but they're packaged the same, so it was easy, and the names sound alike. That's the biggest thing. Not only did they have a sound-alike name, dopamine, dobutamine, but they were packaged the same, so it was easy to pick up the wrong bag, or easy to think, oh, I came for dobutamine, and pick up dopamine. So high alert drug, 2 people have to verify that it's the correct drug that the patient is getting. It comes intravenous, it's not given orally, because of course it will be broken down by those by COMT and MAO. So yes, it's diluted in normal saline, and it's given intravenously only. Now, dobutamine is a high alert drug, and this drug has receptor specificity for beta 1 receptors. The only thing this drug does in terms of treating patients clinically is improving myocardial contractility. All right, it's a positive inotrope, as is dopamine, as is norepinephrine, as is epinephrine. But dobutamine is specifically treat heart failure. All right, so it has beta 1 receptor specificity. It is considered a catecholamine, and the side effects: tachycardia, and add on their ventricular dysrhythmias. You start a patient on dobutamine, you got to be watching the monitor to make sure that they're not having ventricular arrhythmias. Okay, so again, more than 6 PVCs in 1 minute is concerning, and then that's something you have to report. Okay, so that's the major side effects. Dobutamine, the minute you start dobutamine, heart rate goes right up. All right, there's no ifs, ands, or buts. You start dobutamine, heart rate will go up. And it's only given IV. Phenylephrine. Phenylephrine is also known as neosynephrine. It has receptor specificity for alpha 1 receptors. And it's a drug that is given intravenously for blood pressure management. All right, I mean, in the ICU setting, and it can be used also. It's used along with, in the eyes in some instances to delay absorption of local anesthetic, but it's used primarily to, and you have phenylephrine sprays over the counter in the nasal sprays to help with the runny nose, right? Because it vasoconstricts the vessels in the nose and decrease flow to those vessels so you don't get a runny nose. But this drug here, when it's used in the hospital setting, it's used for treating patients who have low blood pressure, patients are in a shock state. So phenylephrine, neosynephrine, alpha 1 receptor specificity. Now, the one thing I want to tell you about phenylephrine is that phenylephrine has you get tachyphylaxis. We talked about that earlier in the semester, tachyphylaxis with phenylephrine, meaning that after about 2 days it stops working. All right, and this drug here, 2 days doesn't work anymore. That's tachyphylaxis. All right, so after an IM injection of penicillin, a patient develops severe difficulty breathing and a swollen tongue. Which medication should the nurse prepare to administer? A, B, C, or D? Correct. Epinephrine B. A patient is receiving dopamine. Look at the brand name inotropin. So it's occlusive and it's an inotropic agent for the treatment of shock. What would indicate to the nurse that the medication is effective? A, decreased mean arterial pressure. B, gain of 2 kilograms in 24 hours. C, increased heart rate, D, increased urine output. Patient's getting dopamine, patient's in a shock state. We give dopamine. How do you know that dopamine is working? Yes. Cole, Brittany, you are correct. D. It increases renal perfusion and patients will start to urinate. If loss of 2 kilograms in 24 hours, that would mean the drug is working too, because that's what we want to see when we're treating heart failure. All right, dopamine raises the blood pressure, so the patient will have not decreased mean arterial pressure, but increased mean arterial pressure. And yes, dopamine will increase the heart rate, but that's a side effect. It's not medication effectiveness. 3, a patient is started on dopamine infusion for the treatment of acute decompensated heart failure. The nurse should assess the patient for the major adverse effect of dopamine therapy, which is A, B, C, or D. Supraventricular tachycardia, fine hand tremors, AV block, hyperglycemia. A, B, C, or D. What is the side effect of dopamine? We only talked about one of them. But no, actually we talked about 2, but they kind of tie in together, yes. That's Cole, Brittany, Jen, yes. Tachycardia and dysrhythmias. Fine hand tremors you can get that from the catecholamines such as epinephrine. All right, the ones that are symptomatic agents. You can get fine hand tremors when they're activating the beta receptors. The nurse cares for a patient with asthma who uses albuterol. The nurse is most concerned if the patient makes which of the following statements. The medicine in the inhaler helps me to breathe. I can use the inhaler as often as I need it. My hand starts to shake after I use the inhaler. If the inhaler doesn't work, I should call 911. What would make the nurse concerned? Let's go through this. See. Okay, I can see why you would pick C. So I think B is a better answer. Yeah, I think B is a better answer because no medication can be used as often as needed, especially one that activate the beta receptors and increase the heart rate. So yes, it is concerning that the hand starts to shake after they use the inhaler. All right, and that you usually see with excessive use when you're using it as often as you think you need it. So the right answer for this is wait a minute. I can use the inhaler as often as needed. I can use the inhaler as often as needed. No, you cannot. Um, and then I guess, and if they were asking for side effects, then the handshaking would be concerning because it does cause tremoring. Even in you get an albuterol treatment, patients get tachycardic, and even the meter dose inhaler can raise the heart rate and cause patients to tremor. But usually you don't see it with using the standard 2 puffs every 4 to 6 hours. You see it when they're using it too much or they're getting nebulizer treatment. Some patients are very sensitive to it. Next is done. Okay. Any questions? That was 17. Pull up 18. Okay. Adrenergic antagonists. As a nurse, you'll be using um, adrenergic antagonists quite often in your clinical practice. Or they cause direct blockade of adrenergic receptors. Let's make sure. Okay. Most adrenergic antagonists are more selective than the adrenergic agonists, and we'll talk about the individual. So there are two major groups of adrenergic antagonists. They're the alpha adrenergic blocking drugs, which I mentioned before, we use to treat high blood pressure, and we also use to treat overdose of alpha 1 adrenergic agonists, and we also use them to treat prostate symptoms. Okay, and a number of other conditions we use them for. And then the beta adrenergic blockers, we use them for a wide range of conditions as well. Um, Most often, high blood pressure, we use them for heart failure, we use them for anxiety, we use them to block the effects of other medications. Okay. Therapeutic applications of alpha blockade, high blood pressure, lowers the blood pressure by causing vasodilation by blocking the alpha 1 receptors in the arterioles and the veins. In response to venous dilation, there's decreased venous return of blood to the heart, and hence there's decrease in cardiac output, which lowers the pressure in the aorta. Arterial pressure is also reduced so you have reduction of arterial and venous pressure, but the end product is decreased arterial blood pressure. All right. So again, we use alpha blockers for reversal of toxicity from alpha 1 agonists, overdose of alpha adrenergic agonists, hypertension due to excessive activation of alpha 1 receptors on the blood vessels. The reversal agent is an alpha reversal. It's used as a reversal agent. If you have a patient who, for example, is overdosed on any of the catecholamines, we can use alpha blockers. Extravasated necrosis, infiltrate the region with phentolamine, which works 2 ways, and we'll talk about the second way in a little bit. But so we want to infiltrate the region with phentolamine, which is an alpha adrenergic antagonist, and it will cause vasodilation in the area, and it blocks vasoconstriction and prevents injury. The drug is used to treat the symptoms of BPH, and we know BPH is an enlarged prostate. And these patients, when they're symptomatic, they complain of urinary frequency, nocturia, urinary frequency at nighttime. So they get hyperplasia of the prostate, and it squeezes on the urethra and interferes with proper, it leads to incomplete voiding. And so these patients go regularly. So they have increased daytime urination, they have nocturia, they have dysuria or dysuria, painful urination. And they have hesitancy. They start and then they don't stop. They feel like they haven't completely emptied their bladder. All right, so for these patients, we treat their symptoms by blocking the alpha 1 receptors around the prostate. And so reduce the contraction of the smooth muscle in the prostatic capsule and the bladder neck, and allows for better passage of urine, hence decreasing the symptoms. Okay, so now if we block too much, all right, we can get hypotension. Okay, so orthostatic hypertension. One of the questions that the boards like to ask, or some of the test questions that come up, is your patient is starting an alpha 1 blocker for treatment of BPH. When do you instruct the patient to take the medication? And the right answer will be take it at nighttime. The reason we give it at nighttime before going to bed, is because this medication can cause the patient to, if they take it and they're walking around, especially the first time, all right, they can pass out. All right, so we tell them take it at nighttime when you're lying in bed already, all right, or just about to go to bed, because of orthostatic hypotension and the risk of syncope. All right, so again, this drug, they block the alpha receptors on the veins, and by blocking the alpha receptors on the vein, it causes venous pooling of blood and decreased venous return to the heart. And so when the patient stands, all the blood is pooled in the veins, and there's not enough coming back to the heart, hence not enough going to the brain, they pass out. All right, so orthostatic hypotension. Reflex tachycardia is a response to orthostatic hypotension. And so patients will get a reflexive tachycardia. Nasal congestion, these drugs can dilate the blood vessels in the nasal mucosa. So it does the opposite of phenylephrine, right? So we use phenylephrine, which is an alpha adrenergic agent, to decrease nasal congestion by blocking blood flow to the nasal mucosa, decreasing blood flow to the nasal mucosa. This is the opposite. This causes nasal congestion because it dilates the blood vessels in the nasal mucosa, leading to nasal congestion. You need alpha 1 activation for proper ejaculation, and so this drug can inhibit proper ejaculation. All right, and it's reversible when the drug is discontinued. And of course, it can lead to sexual dysfunction as well because it decreases the blood flow to the penis. It leads to sodium retention and increased blood volume, and this again is due to activation of renin, aldosterone, angiotensin. So the reason that happens is when there's venous pooling, there's less blood coming back to the heart, hence less blood going to the kidneys, and then the kidneys, the pressure is less. The kidneys, they're very sensitive to decrease in pressure, and so will activate renin. And then it leads to volume retention and sodium retention. All right, so when we give these patients, we usually will combine the drug with a diuretic to counteract the effects of renin activation. There's another drug that we do that with too, and those are the blood pressure medications called calcium channel blockers that we're going to talk about a little bit. So sodium retention, increased blood volume, or it can lead to the patients presenting with swelling of the legs. So we'll give them the diuretics before they show up with the swollen ankles. All right. Adverse effects of alpha 2 blockade, all right, is potentiation of reflex tachycardia that happens when there is blockade of the alpha 1 receptors. All right, and this has to do with release of norepinephrine in response to orthostatic hypotension that stimulate the beta 2 receptors, and hence it will cause heart rate to go up. So these are the drugs that are the alpha adrenergic antagonists, and if you notice, many of them they end in zosin. Excuse me. So prazosin, terazosin, doxazosin, tamsulosin, alphazosin, and then phentylamine is in the bottom there, and you know phentylamine is an alpha adrenergic blocking agent. So I think someone, and I forgot to go back to the question. Someone, so we have to know the drugs and we have to know the classes. I think it was, who asked that question? Tyler, I think, asked that question. Yeah, you do have to know the drug names. You don't have to know all the drug names. But if you know, for example, like the prototypical drug here is prazosin, right? And you know this is an alpha blocker, then the alpha blockers, you know, will do, all the alpha blockers will pretty much have the same side effects. Tamsulosin is a little different than the prazosin, terazosin, doxazosin because it only is specific for the prostate. Same thing for alvazosin. So if you're being given a question, it's not going to be, you don't have to know all the drugs, but you should know, the LOL is a beta blocker, Pril, there is inhibitors, Zosins, those are alpha adrenergic agents, alpha adrenergic blocking agents. And sometimes, if it's a drug that's like out there where, you can't really make an association to the class of drug, then you may be told in the question, blah, 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 is an alpha adrenergic antagonist. And the patient's receiving it for X, Y, and Z. All right. So let's talk about these drugs. All right, so we have, prazosin, we have terazosin, doxazosin. These are drugs that are used to treat both high blood pressure, prazosin, terazosin, doxazosin. They treat high blood pressure and they treat BPH. All right, so again, I'm just going over prazosin is an older drug, and you probably will see doxazosin more than you see prazosin. That's why I'm just going over doxazosin, but they have pretty much the same mechanism. They have the same mechanism of action, the same indications, and for the most part, similar pharmacokinetics. So prazosin is the prototypical drug in this class. It's an older drug. We use a lot of doxazosin today. So what does doxazosin do? Doxazosin is selective competitive inhibitor of alpha-1 adrenergic receptors, and it's used to treat both hypertension and BPH. So it has selectivity. Some of the like phentylamine doesn't have selectivity, nor does phenoxybenzamine, that doesn't have selectivity. So we don't really use those on a regular basis. We use the ones that are highly selective because you have less side effects when they are highly selective. So this drug, doxazosin, is given orally. Peak effects develop after 2 to 3 hours. The half-life is about 22 hours. It's once a day dosing. It's highly protein bound, and so that's why the half-life is 22 hours. And it's metabolized by the liver, and it's excreted via the biliary tract. Now, we usually dose these patients once a day with this medication because it does have a long half-life. Right? Adverse effects, and you'll see the same theme with all of the Zosyn drugs. All right? Orthostatic hypotension, all right, very common. Dizziness, very common side effect. Reflex tachycardia due to venous pooling. Nasal congestion, we just talked about that. And as I said before, when we're starting this drug, we want to tell the patients to be in bed. And we usually order it at bed anytime, anyways, all right, because of the first dose effect. What's the first dose effect? Pressure drops, patient syncopizes, all right? So first dose effect, they get drop in blood pressure and they can syncopize. So we have to monitor them carefully. Tamsulosin is an alpha adrenergic antagonist. It causes selective block. It's specific for the prostate. It causes selective blockade of alpha 1 receptors of the smooth muscle of the bladder neck. All right, that's trigonal sphincter that needs to relax in order for urine to adequately flow, and the prostatic capsule that also needs to relax, as well as the prostatic urethra. Blockade of vascular alpha 1 receptors is weak, hence it is not used to treat blood pressure. It's only approved for BPH. The most common side effects, headaches and dizziness. Yes, yes. All right, patients get headaches. They complain of dizziness. It can also lead to retrograde ejaculation, meaning that ejaculation goes in the opposite direction. Okay, or ejaculation failure or decrease in ejaculation, and it can lead to runny nose. In terms of drug interaction, there might be possible toxicity with cimetidine. Cimetidine is a drug that is it affects CYP. It's a CYP inhibitor. All right, it's a potent CYP inhibitor. All right, and when you give any drug that is a potent CYP inhibitor, it interferes with the drug levels in terms of causing drug levels of tamsulosin to go up. All right, so it can cause more adverse effects. All right, so in terms of drug interactions, given it with drugs that cause hypotension, such as the phosphodiesterase type 5 inhibitors, that's sildenafil, all right, tadalafil, those drugs, the erectile dysfunction drugs, it can lead to significant reduction in blood pressure. So we caution our patients, and I try not to mix them. Right, phentolamine is also known as Regetine. It's a competitive adrenergic antagonist. It blocks the alpha 2 receptors as well as the alpha 1 receptors. It's approved for the treatment of pheochromocytoma. Pheochromocytoma is a condition where there is a tumor on the adrenal gland that releases catecholamines and causes the blood pressure to get really, really, really high. And so this drug is approved for the treatment of pheochromocytoma. And again, it's used for prevention of tissue necrosis after extravasation of drugs that produce alpha 1 vasoconstrictors, such as dopamine and epinephrine and norepinephrine, and reversal of soft tissue anesthesia. Adverse effects: orthostatic hypotension, reflex tachycardia, nasal congestion, inhibition of ejaculation. It's contraindicated in patients who have angina and myocardial infarction. All right, and it can cause profound hypotension, which we can treat with norepinephrine, which stimulates the beta 1 receptors. A patient is receiving a drug that blocks alpha 1 adrenergic receptors. Which adverse effect, if experienced by the patient, is the most concern to the patient? A, B, C, or D? None. Okay. A, B, C, or D? D. Okay. Anybody else? Okay, so the right answer is B. Reflex tachycardia is an issue. It just makes the patient uncomfortable, but Orthostatic hypotension is more problematic because patients can syncopize and fall. A nurse instructs a patient about doxazosin, which is also known as Cardura, which statement by the patient to the nurse indicates an understanding of the instructions. It's common to have nightmares and insomnia. I need to take the medication in an empty stomach. The medication should be taken tonight before I go to bed. I should stop taking the medication if I feel lightheaded. Anybody else? Yes, the correct answer is the medication should be taken at nighttime before bed so as to prevent falls. Number 3, a patient with type 2 diabetes is diagnosed with stable angina. Patients with type 2 diabetes, angina, which beta blocker, if prescribed by the physician, would the nurse question? So I didn't teach you this, but here we go. We didn't go over beta blockers yet. We'll go over beta blockers in the next chapter. I specifically didn't cover it only because we have a whole chapter on it, and after a while it becomes redundant. It's in the high blood pressure chapter, it's in the heart failure chapter, it's in the anxiety chapter, and then it's in the beta blocking chapter. All right, so we have, when we're dealing with drugs that are beta blockers, we have some drugs that are more likely to cause certain things. So we have drugs that are beta selective, meaning that they're more selective for the beta 1 receptors in the heart versus the beta 2 receptors in the lungs. We have some that will make a patient not feel hypoglycemia when they're diabetic, all right, versus the next one that may not be as bad. So in this case here, a patient type 2 diabetes diagnosed with stable angina, which would the nurse question. So the right answer for this one here would be B, Nadolol Corgard. All right, and we'll talk more about these beta blockers in the hypertension chapter. The nurse prepares to administer metoprolol. Again, this is another beta blocker question to the patient with chronic stable angina. What is the priority assessment to make sure before the administration of this drug? Whenever we're giving anything that affects blood pressure and heart rate, we must check the vital signs prior to, so as to have a baseline. So you're giving a beta blocker. What do we want to check? Right, the heart rate, because it's going to lower the heart rate, and it's also going to lower the blood pressure. Okay. Any questions? Okay. What time is it? Time is flying by. 18. What's the next chapter? 21. Excuse me. Thank you. Oh my God, I've been holding it in. I've gotten real good at holding in my coughs and my sneezes because, everybody thinks you have COVID and they get upset when you sneeze and you cough. So I've learned. I've been trying to do it even when I was sitting here. Hang on one second. Let me just get back to where you are so I can. 21. Okay.
Professor?
Yes.
On week 5, you also have chapter 19.
Chapter 19 is, what is that again? Remind me?
Indirect acting anti-adrenergic agents.
I'm sorry, say that again?
Indirect acting anti-adrenergic agents.
Oh, hold on one second. Then, yes. Hold on. Let me find that. Thank you for telling me. I thought I downloaded all that I needed to download from in preparation for class, but I must have missed one. Hold on 1 second, please. You can take a 5-minute break because I just need to use the ladies' room and I'll be back. But let me pull that up. Thank you for telling me that. What is it? 3:12. Okay, let's get started with indirect acting anti-adrenergic agents. Right. Okay, so there are a handful of drugs that we use that work centrally in controlling high blood pressure. And there are some standout things that you need to know about these drugs. So how these drugs work is they work by reducing the firing of the sympathetic neurons, and they will act on they will act to agonize the alpha 2 receptors in order to reduce these the firing that would cause an increase in heart rate, increase in blood pressure. So the effects are similar to those of the direct acting adrenergic receptor blockers, and the drugs that we use in this category, clonidine, we use clonidine, and we use methyl-dopa as well. And methyl-dopa is approved for use in pregnancy. We also use it for pain. We use a lot of these drugs for, like clonidine, for example, it can be used for pain management, even though we don't typically see it being used as a pain medication, but it is a drug that's indicated for severe pain. We use it for attention deficit hyperactivity disorder, and on here you can also add we use it for patients who are detoxing from opiates. So the drug comes, clonidine, the drug comes in multiple different formulations, and it can be given orally. It can be given as a patch. It can be given as an epidural. So there are multiple ways we can administer clonidine. Most often you'll see it given to treat blood pressure, high blood pressure. There's not even the first line, it's not even the second line. Because of the side effects of clonidine makes the patient very, 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 very drowsy. It will put some patients to sleep. And so the risk, of giving this to somebody who's older is significant because of the risk of falls. Additionally, it can cause, well, the most common side effect is dry mouth. Like half of the people who take clonidine, they get dry mouth. But another side effect is bradycardia and decrease in cardiac output. And so it can have side effects in patients who have a congestive heart failure. But the biggest concern with this drug is the drowsiness, and of course abuse. People abuse clonidine as well when they have opiate addiction. It's a drug that when patients come into the hospital and they are withdrawing from opiates, we can give them clonidine to help with the withdrawal symptoms. So the drug is highly lipid soluble, and so it's readily absorbed right after oral dosing. And so you see patients, it works real fast. Within 30 minutes, the patient's blood pressure is down. And this is a drug that I keep in the office. So if I see a patient who comes in, the blood pressure is like 220 systolic, and rather than send them to the emergency room, I'll give them a dose of clonidine, check the blood pressure half an hour if they want to do it, if they want to sit around the office. Usually I tell them go to the ER. But if they refuse to go to the ER, which many of them do, I'll give them some clonidine in the office, check their blood pressure in like 30 to 60 minutes, and you'll see the blood pressure will come down from 220 to like 140, 130, 120 after about an hour or so. And it's a very potent drug. I remember one time a nurse called me, a patient's blood pressure was in the 200 range, and I ordered 0.1 milligram of the drug. And the nurse said to me, "That's it, 0.1?" I said, "Yeah, that's it, just 0.1." And she said, "I don't think it's going to do anything. The pressure is so high." An hour later, she called me back. She goes, "Oh my God, the patient's blood pressure is down to like the low 100s." I said, "You see? Because it works fast and it works and it's potent in dropping the pressure." All right, so they do get hypotensive with this drug. All right, so there are 2 approved applications for hypertension and severe pain, but it's used, off-label for opioid and methadone withdrawal, and it's also used for like smoking cessation. It's used for treating, a number of different behavioral conditions in kids. And it can also be used for tics, like patients who are having tics. Tourette syndrome, and it can be used for like oppositional behavior when kids have it. So there are a number of different reasons why we use clonidine. But again, clinically, when you become a nurse, the most often time you'll see it used is to treat high blood pressure and occasionally to treat opiate withdrawals in patients who are opiate abusers that are hospitalized. So adverse effects, it causes central nervous system issues and depression. So patients will complain of drowsiness. Sometimes I give the patient the clonidine in the office, and I walk by them like 30 minutes, and they're asleep. So it can literally put you to sleep in half an hour. And the patients who it affects. Xerostomia, dry mouth, big side effect with clonidine, to the point where sometimes the patients just stop taking their medications because it's so uncomfortable. And then in that case, you tell the patient, you can suck on some sugar-free sour candy to help with production of saliva. It can cause rebound hypertension. You gotta withdraw it slowly. You can't just stop it because the blood pressure will go whoop, sky high. Same thing happens with beta blockers too, by the way. You stop beta blockers too quickly, abruptly, rebound hypertension, blood pressure goes through the roof. All right. Use in pregnancy is not recommended. It's okay for methyl dopa to be used in pregnancy, but clonidine cannot be used in pregnancy. All right. Abuse. All right. People who abuse certain street drugs like opioids, like the heroin, and morphine and Percocets, even cocaine. All right. They also will abuse clonidine as well, because at very high doses, the patients can feel high. They feel euphoric. They get the same high that they do when they use street drugs like opiates. So they get really, really high. In really high doses, they can get sedated and they can also hallucinate. Additionally, they also use clonidine because it intensifies the effects of some drugs that people abuse, like opioids and cocaine and Xanax. So, so patients will come. The blood pressure is like 120 systolic, and they'll say, "I'm here for my clonidines today." I'm like, your blood pressure is normal. You are not on the first line high blood pressure medicine because it's not first line, and I'm not giving it to you. And after that, they get very upset with me. But it's not good practice to give somebody clonidine, whether they're abusing it or not, as first line drug. There's so many different drugs that we can use for high blood pressure to manage. So many drugs we can use to manage blood pressure before we get to clonidine. In the line of antihypertensives, clonidine is probably fourth on the line. All right, in terms of classes of drugs to give. So, but patients will come in and they will, if they have an opiate problem, they will fight you for clonidine because it intensifies the high that they get, so they spend less money on the drugs. So it boils down to a financial issue, is that they can get the same high for less price if they combine it with clonidine. Other adverse effects, it can cause constipation. That's a very common complaint as well. Constipation, right? And impotence and gynecomastia can also occur. Now, clonidine, and so clonidine comes orally for blood pressure management, and can get as a patch, the catapress patch. The patch stays on for 7 days. The clonidine tablets, they come in 3 different dosages. And of course, the patch you have to put on the hairless area, and you rotate the site. Make sure that you take off. Make sure you take off one patch when you're applying the other one, because it causes significant bradycardia if you have 2 patches on, a significant hypotension. Okay, and then Duraclon clonidine is for intradural or epidural, administration for pain management. Methyl-dopa lowers blood pressure by activating the sites within the central nervous system. It causes alpha-2 activation. It's not an alpha-2 agonist. All right, and again, it causes vasodilation, no cardiosuppression, lowers blood pressure. is used for treatment of hypertension, and it is approved for treating blood pressure in patients who are pregnant. Adverse side effects: patients can get hepatotoxicity. All right, so we have to monitor their liver function, monitor for signs of hepatitis, jaundice in these patients when they're taking these medications. They can get what's called a positive Coombs test in a small percentage of patients, actually in more than a small percentage of patients who take methyldopa chronically. And this is not a drug that you see often. I have prescribed methyldopa one time because we have, more drugs nowadays to treat patients with that, have less toxicity or less side effects. But in a good percentage of the patients, in about, 20% of the patients who take methyldopa chronically, they get a positive Coombs test. And what it means is that these patients, they get this hemolytic anemia in response to taking the medication. And you'll see it usually within the first year of taking it, you'll see that they develop hemolytic anemia. So having a positive Coombs test doesn't necessarily mean that the patient is having, active hemolysis. So they can, once it turns positive, they can progress to getting hemolytic anemia. And that's why it's important that we monitor these patients for hemolytic anemia. If they do get hemolytic anemia, we have to stop the drug. We can't give it to them anymore. If they don't, then it's safe to continue the drug. Once they stop the drug, the hemolytic anemia goes away. The Coombs test, though, doesn't become negative right away. It takes time for the Coombs test to become negative again. A patient plans to stop taking prescribed clonidine to treat hypertension because of the side effect of dry mouth, which action by the nurse is best. Tell the patient that dry mouth is not caused by clonidine. Give the patient hard candy or gum to relieve the symptom. Instruct the patient to stop taking the medication immediately. Advise the patient to take a reduced dose of the medication. Yes, Tyler. So yes, the right answer is give the patient hard candy or gum to relieve those symptoms. B is correct. All right. So now I think we're going to, where are we going to next? 20.
Professor, just
Yes.
to clarify, so the Coombs test it's checking for anemia. It's not checking for signs that a person is predisposed to anemia, correct?
So the Coombs test will do, it's a test to look for a reaction. It's an antiglobulin test to look for a reaction to the drug, and it's looking for antibodies that's been created against the red blood cells, and you see them stuck to the red blood cells. And if that does not cause hemolytic anemia, then that's fine. The patient can go on with the medication. But if it prompts or triggers anemia, then the medication has to be stopped.
Gotcha. Thank you.
Okay, you're welcome. Alrighty, let's talk about drugs for Parkinson's disease. So this is a quick chapter as well. All right, so Parkinson's disease, we covered Parkinson's disease last semester. It's a neurodegenerative disorder of the extrapyramidal system that affects motor function, and it's characterized by dyskinesias and akinesia. So there is an imbalance between dopamine and acetylcholine, and I think the book has a great picture. I'll put the pictures in here, but the book has a great picture that shows the imbalance between dopamine and acetylcholine, where you have more dopamine than you have acetylcholine.
No, sorry, I'm not sure if it's just me, but I can't see your screen.
Sorry.
It's okay.
One sec. Thanks for letting me know, because I did have. Okay, I think we're good now. Thank you. Alrighty, so Parkinson's disease is a motor dysfunction, and it affects more than 1 million people in America. Second only to Alzheimer's disease, is the most common degenerative disease of the neurons. Its symptoms generally appear during middle age and they progress. There's no cure for motor symptoms. The medications just control the symptoms, but it doesn't cure the disease. So drug therapy can maintain functional capability for years and improve quality of life. So the cardinal symptoms of Parkinson's disease: tremor at rest. That's what tells you a patient has. Well, that's what leads to a clue that the patient might have Parkinson's disease. Right? They have tremor at rest. We talked about this last semester. Rigidity, postural instability. They walk with they walk lean forward. All right. They have a mask-like face. Okay. They have bradykinesia. They walk slowly and they don't swing the arms, and they tremor. All right. In addition to motor symptoms, they also have autonomic disturbances that affects multiple autonomic functions. They get depression, and eventually, many of them will develop psychosis and dementia as they get towards the end of the disease. All right, so I'm just going to skip right over this. This is just, here's the chart that I was talking about. All right, so the therapeutic goals. Let's get to medication. All right, so therapeutic goal, ideally, and there's no ideal drug for Parkinson's disease, we want to reverse the neuronal degeneration or prevent further degeneration. But there is no drug that does that. The goal is to improve the patient's ability to carry out the activities of daily living. The overall goal is to improve quality of life. So drug selection and dosages are determined by the extent to which Parkinson's disease interferes with work, dressing, eating, bathing, and other ADLs. So there are two major categories of drugs that we use to treat Parkinson's disease. They're the dopaminergic agents, and these are by far the most commonly used drugs for Parkinson's. And they promote activation of dopamine receptors. All right, and in this, did I say acetylcholine before? There's an imbalance between acetylcholine and dopamine, where you don't have enough dopamine, and you have more acetylcholine. So levodopa is the mainstay of therapy. It may not be the first line drug, but if you give somebody Parkinson's disease levodopa and they don't improve their symptoms, it's unlikely that they have Parkinson's disease, because this drug is that effective in increasing the dopamine levels and improving motor function. So, and then we can use the anticholinergic agents that prevent activation of the cholinergic receptors. And we talked about the centrally acting one is called benztropine. So in terms of initial treatment, all right, it's all based on symptoms or symptomatology. Mild symptoms, we can use the MAOB inhibitors. All right, and we'll go through all of these drugs in a little while. This is selegiline, rasagiline, all right, and your monoamine oxidase B inhibitor, and they block the enzyme that breaks down dopamine. And then the more severe symptoms, we use levodopa, and it's combined with carbidopa, because carbidopa prevents the peripheral breakdown of dopamine. If you were to give levodopa by itself, not much of it would get to the brain, because peripherally it will be broken down before it can get to the brain. So it's always combined with carbidopa, and it's sold as Sinemet. Okay, so carbidopa prevents the breakdown of dopamine once levodopa gets converted to dopamine. We can also use a dopamine agonist in patients who have more severe symptoms. So levodopa is more effective than dopamine agonists, but long-term use carries a significant risk for disabling dyskinesias. And when you're dealing with these patients, it's a matter of what side effects they're willing to tolerate. So when patients have Parkinson's disease, they have off times, or they have motor fluctuations, and usually comes towards the end of their dosing period. So if they're almost due for, at the time you're almost due for a drug, or towards the time that they're due for the next dose, they may have, exacerbation of their Parkinson's syndrome, Parkinson's symptoms. So off times, we reduce these off times by adding a dopamine agonist. We can do a COMT inhibitor, or we can do an MAO-B inhibitors. Again, these drugs are prone to causing drug-induced dyskinesias, and they can be disabling. They can be mild, where it's just annoying, or it can be very disabling to the point where the patient has to come off of the medicine. All right, so there's no drug that's been shown to actually show neuroprotection in human beings. Now, levodopa is only given in combination with carbidopa, and it's also given as a fixed dose in a drug called, it's in a combination with entacapone. This is another drug that's used to decrease off times or those motor fluctuations in entacapone. So there's a combination of levodopa, carbidopa, and entacapone. That's 3 drugs in one, and they have fixed doses. Advantages and disadvantages to that. But the drug also comes as a drug called Sinemet. Sinemet is the brand name for levodopa, carbidopa. So levodopa is highly effective, but the benefits diminish over time. Orally administered, it's rapidly absorbed from the small intestine. Food delays absorption. And neutral amino acids compete with levodopa for intestinal absorption and for transport across the blood-brain barrier. Hence, high-protein foods will reduce the therapeutic effects of levodopa. So levodopa is a drug that was introduced in the 1960s. It's the cornerstone of Parkinson's treatment ever since. It's highly effective. However, the disadvantage of it is that they get dramatic improvement initially, but by 2 years, the improvement that they've seen will start to eventually wear off. And by year 5, they are already back to, many instances, not all instances, but in many instances, they're back to their pre-levodopa symptoms. So, and then really, it's just due to progression of the disease, because it's a progressive motor dysfunction, and not really that the drug is not working anymore. It's just that the drug is no longer working for the progressive state or the progressed state. All right. So levodopa, the biggest thing you want to remember, levodopa is dyskinesias. Levodopa causes dyskinesias. Levodopa causes dyskinesias. All right. It's always combined with carbidopa so that we can give the patient a lower dose. Why? Because carbidopa prevents the breakdown in the periphery. All right. So acute loss effect. All right. This often can either be a gradual loss or an abrupt loss. Gradual loss is called wearing off, and wearing off effect develops again near the end of the dosing interval and indicates that the drug levels have declined to a subtherapeutic level. So that's the gradual loss. So whenever we have wearing off, we can minimize it by either shortening the interval dosing. Sometimes you see patients on Parkinson's medications 5 times a day, which is unusual when you're in a hospital setting to give somebody medications, to dose them 5 times a day with the same medication. But that's a means by which to decrease the wearing off, all right, or the off times. All right, giving a drug that prolongs levodopa's plasma half-life, such as entacapone, or giving a direct-acting agonist. Those also will decrease the off time. All right. When we're talking about an abrupt loss, those are gradual loss. An abrupt loss of effect can also happen, and this is known as the on-off effect. The on-off effect can occur anytime during the dosing interval, even when the patient has high levels of drug in the body. So the gradual wearing off is when they're coming to the end of their dosing interval and they're subtherapeutic. But the on-off effect, even if they have therapeutic doses, all right, they can have off times that last for short periods of time or for long periods of time. It can be hours, it can be minutes. Okay, and so, and as the patient progresses as well, the off times become more frequent. And of course, we can give them drugs, again, like dopamine agonists, that can help prevent these off times from occurring. So levodopa reduces symptoms by increasing dopamine synthesis in the striatum. It enters the brain via an active transport system that carries it across the blood-brain barrier. Carbidopa does not cross the blood-brain barrier, only the levodopa. And once it gets into the brain, uptake into the remaining dopaminergic nerve terminals occurs, and it will increase motor function. Levodopa by itself has no direct effects of its own. It has to be converted to the active form, dopamine. And levodopa helps restore that balance between acetylcholine, and it will increase the dopamine levels to keep that scale of acetylcholine and dopamine balanced. Now, there's an enzyme that catalyzes that reaction of levodopa to dopamine, and it's called decarboxylase. All right, decarboxylase activity is enhanced by vitamin B6. Adverse effects, you'll see the same kind of adverse effects over and over again with the Parkinson's medication. For levodopa, definitely nausea and vomiting. Outside of the dyskinesias, I want you to put secondary to dyskinesias. Most common is nausea and vomiting. Most concerning, dyskinesias. So nausea and vomiting. Carbidopa by itself is an antiemetic, so by combining levodopa and carbidopa, it also helps control some of the nausea, but the patient can still have nausea and vomiting. All right, and this happens due to activation of the chemoreceptor trigger zone in the brain that's responsible for triggering vomiting. So low initial doses and administration with food can reduce the therapeutic effects by decreasing levodopa absorption. Giving additional carbidopa without levodopa can help reduce nausea and vomiting. It never happens. There's usually carbidopa comes sold with the levodopa. All right, but we can use other antiemetics, and that's what's usually employed. All right. Of course, we have cardiovascular effects that occurs with this medication. It can cause significant postural hypotension, especially when the patient first starts the drug. All right, so we have to monitor a patient for hypotension. All right, so if we want to counteract the effects of the hypotension, which oftentimes happen, we can also give them a drug that's an alpha adrenergic agent to help counteract that. Oftentimes that's not necessary. All right. Increase in intake of water and salt if the patient can do that to help with the postural hypertension. I mean, some patients may not be able to do that because they have heart failure. So if it's not contraindicated, then sure. All right. Another adverse effects in a good percentage of patients who get levodopa treatment, they develop psychosis and they have a lot of neurobehavioral symptoms. They have visual hallucinations. They get vivid dreams or nightmares. Vivid dreams or nightmares, I often think of levodopa and beta blockers. Beta blockers cause vivid dreams or nightmares as well. All right, so vivid dreams, nightmares, well, not just levodopa. Many of the Parkinson drugs cause vivid dreams and nightmares. Patients can get paranoid, so they get neurobehavioral symptoms when they start these drugs. And it's just a matter of, trying to figure out which is the right dosage to, prevent the side effects. You can lower the dosage to see if it helps, but if you lower the dosage, then the patient's motor function will go down the toilet. So it's a balance. Our central nervous system affect anxiety and agitation, memory, cognitive impairment, insomnia, nightmares are common with these patients. Oh, many of the Parkinson drugs, they cause impulse control. Some of the drugs will cause patients to start gambling, like they have money when they don't, and some of them may even end up having like promiscuous behavior with these drugs. So they have behavioral changes that's associated with promiscuity, gambling, binge eating, and alcohol abuse. Dyskinesias, most concerning. Dyskinesias. So levodopa is given to alleviate movement disorders, but it can cause movement disorders too. Okay. Levodopa can cause movement disorders, and that's what the boards will test you on. Some are just annoying, and then others are disabling. And they develop just before or soon after optimal levodopa dosage has been achieved. So again, we can manage the dyskinesias by either reducing the dosage, but it'll reduce the beneficial effect of the drug. We can do amantadine. Amantadine is Symmetrol. This is a flu medication. All right, we don't use it for flu anymore because now we have other drugs. But this drug was first developed to treat flu, and now it's the only approved drug to treat dyskinesias induced by levodopa. Other things you can teach your patients is that the drug can darken the sweat and the urine, and so they should know that's harmless. And another thing that it can do is activate malignant melanoma. So we have to do a thorough skin assessment when we prescribe this drug for the patient. All right, so in terms of drug-drug interactions, first-generation antipsychotic drugs, for example, haloperidol, chlorpromazine, they block receptors for dopamine in the striatum and decreases the therapeutic effect of dopamine. MAO inhibitors, levodopa can cause a hypertensive crisis if administered to an individual taking a non-selective MAO inhibitor, which makes sense. Anticholinergic drugs, excessive stimulation of cholinergic receptors contributes to dyskinesias of Parkinson's disease by increasing acetylcholine. Okay. So by using anticholinergic agents, we can enhance the responses to levodopa. Like we use benstropine, right? Pyridoxine, vitamin B6. We don't really use it. It stimulates decarboxylase activity. Acceleration of decarboxylation of levodopa in the periphery will increase the amount of dopamine. Pyridoxine can decrease the amount of levodopa available to reach the central nervous system. So limit pyridoxine because it can increase the breakdown of dopamine in the periphery. So it increases the decarboxylation of levodopa in the periphery, so not enough gets to the central nervous system. So, back in the day, they would say, don't, before they started mixing it with carbidopa, they say, you can't take vitamin B6. But now carbidopa protects levodopa from being broken down in the periphery, and so pyridoxine use is not an issue anymore. All right. Food interactions?
It's up to 350.
Oh, thank you so much. Yes. Let me finish up levodopa. Thank you, because I have my next class in 10 minutes. So levodopa, there is interaction with a high protein meal. So your boards may ask you something like, decreasing the absorption of levodopa with high protein meals. Another thing is levodopa can also have an interaction with antacids. Antacids can decrease the effectiveness of levodopa. All right, so if the patient, we all have to have protein, we can instruct them to spread out their protein consumption evenly throughout the day. All right, so again, levodopa carbidopa is the most effective therapy for Parkinson's disease. Carbidopa is used to enhance the effects of levodopa. B6 is not an issue anymore because carbidopa protects the decarboxylation of levodopa in the periphery, so more is available for the central nervous system. Carbidopa by itself has no therapeutic effects of its own. It's an antiemetic, but really we don't use it as an antiemetic. And carbidopa inhibits the decarboxylation of levodopa in the intestines and the peripheral tissue. And more levodopa is available in the central nervous system because of this combination drug called levodopa carbidopa, because carbidopa is now never ever sold separately. It's always sold. Levodopa is always sold with carbidopa, never sold as levodopa by itself. And so it increases the effectiveness of the drug at a lower dose, hence decreasing the risk of dyskinesias. That's the most concerning side effect, is that dyskinesia. So we don't have to give the patient a whole lot because the concern of decarboxylation is not there anymore due to carbidopa. Carbidopa, as I said before, doesn't cross the blood-brain barrier. Only the dopamine will once it's converted. So let me just finish these last two slides and then we will stop. So the advantages to levodopa and carbidopa. By increasing the fraction of levodopa available for action in the central nervous system, I mentioned this already, carbidopa allows the dosage of levodopa to be reduced by 75%. 75%, hence decreasing the side effects of levodopa, because you're giving a lower dose. By causing the direct inhibition of decarboxylase, carbidopa eliminates concerns about decreasing the effect of levodopa by taking a vitamin preparation that contains pyridoxine. Disadvantages: carbidopa has no adverse effects of its own. Any adverse responses from carbidopa-levodopa comes from levodopa. When levodopa is combined with carbidopa, abnormal movements and psychiatric or neuropsychiatric disturbances can occur sooner and be more intense than with levodopa alone, because carbidopa increases the effectiveness of levodopa. All right. Next week, we will pick up on dopamine agonists. Any questions before we go?
Great.
What are the chances that you'll be able to post grades before you teach your next class?
Let's see. Let me see. Hold on. One hot second.